Okay, so this slide just says here that no one involved in these trainings have any financial relationships to disclose. Here's our grant funding statement. We are funded by the State Opioid Response Grant, which is a federal grant from SAMHSA. I think everyone's familiar with the usual process for CME certificates. There'll be a survey link that's going to come to you in an email about an hour or two after the training. There'll also be a link in the chat. Just complete that quick survey, and your certificate will pop right up. Just a reminder where we are in our current Echo series. We're in the third of the four trainings here. The last one will be in 2 weeks from now. Stephanie Bennington will be doing our final talk. So then we'll be off in December, and then we'll be back again with another cycle of four trainings in January and February. Some more information will be coming out on those fairly soon. You can, if you want to just automatically register for the next session, you can do that in today's um, evaluation survey. There's just a box to click, say yes, register for me for the next cycle. So you can do that either in this Echo session or in the next Echo session's evaluation survey. That's really all I got. I'm gonna stop sharing my screen here and let our Echo panel introduce themselves. Let's see here. I saw Alex hop on. Alex, would you like to introduce yourself?
Sure thing. My name is Alex Dworak. I am a family physician who treats opioid use disorders as part of full spectrum practice. I'm about to drive to another conference on transgender medicine, so I'll have my camera off.
Thank you. Stephanie, would you like to introduce yourself?
Hi guys, I'm Stephanie Bennington. I'm a psychiatrist, primarily located in Western Nebraska. Was in Omaha, but recently relocated. Nice to see you all this morning.
Thanks. And Todd.
Good morning, Todd Stoll. I'm in the Lincoln area and I'm a psychiatrist.
Thank you. Mary.
Sorry, couldn't find the mute button. Morning, I'm Mary. I am a psychiatric nurse practitioner and an attorney. I work mainly in the Omaha and Dodge and Saunders County areas.
Thank you. And John.
Hi guys, good morning. I'm John Massey. I'm a pain doc, mainly in the Lincoln area.
Thank you. And Ed, I'll turn it over to you.
Excellent. Thanks, Will. Yeah, good morning, everybody. Thanks again for joining us. My name's Ed Kaiser, nurse practitioner in the Omaha area. Yeah, really thankful to be with you. Excited to talk about initiation, some of the things that have changed with that. So I've had the opportunity to treat substance use disorder for a little over 6 years. Before I get started, I just want to give a quick shout out and thanks to Ideal Option. That's the company I've worked for the last 6 years. They're located in like multiple states. I think they have 70 locations, but they've really just been generous to me and, helping with some of the material and making it available to educate both providers and just anyone else who's interested in that. And so specifically Dan has been one of my friends that have helped with that. So I'm thankful for that. The longer I've done helped treat substance use disorder, the drug supply has changed, and with the changes in the drug supply, so has our recommendations for initiation. And so we're going to talk about the different sort of strategies this morning and some withdrawal medications that can be helpful. And and hopefully that will be helpful in your practice. I realize not all of you are treating patients with they're using like fentanyl and stuff like that, but I think this can be a helpful tool for us as we better understand it. Just to give you a quick backstory, when I started, it was like heroin was primarily the thing that was out there. Fentanyl was like just getting started, and then we saw more fentanyl, and then went to these like pressed pills that we thought were oxycodone, but were actually pressed fentanyl. And then if you guys remember, it switched over to these like rainbow colored pills. And then eventually we started getting some more xylazine in there. We talked about that a few months ago. And now the thing that's out there right now that's the most dangerous is this fentanyl powder. More and more people are using it. It's more and more potent. And just to give you an idea of how dangerous that stuff is, I was initiating a patient really just within a couple of months, and she was using probably 40 or 50 pills of fentanyl a day. So that was her normal fentanyl use. She was smoking that. We were initiating her onto Suboxone. She was having a little bit of trouble. She decided to use fentanyl one more time, and she smoked some fentanyl with a friend that was the fentanyl powder. And one hit of that for this individual caused an overdose, and she had to get 3 Narcans to bring her back. And so I tell you that story just to say, like, hey, somebody who has significant tolerance in use, even a one-time use of something that's really potent can still really knock them out and be really dangerous. And so, again, as the drug supply has changed, we've kind of changed our recommendations and how to help people get started on the medication. So we'll go over that today. Here's the sort of learning outcomes. We're going to talk about 3 different strategies, kind of describe them and help you understand the similarities and differences with them. We'll talk about a couple different withdrawal med packages and, again, similarities and differences. We'll go over some of the evidence that supports the higher levels of buprenorphine initiation. There's a matrix here that kind of gives you a targeted dose of, hey, whatever someone's using, where are they going to maybe land as far as how much buprenorphine are they going to need. Talk about a few special populations, transitions from methadone, and then just how to help increase, successful initiation with individuals and help the individuals who try to start on it and don't succeed. How do we come back to them and help them as well? So what are we talking about primarily when we're talking about initiation onto buprenorphine? So again, we're really just talking about some of the initial doses of the medication. And what we're trying to do as we start people on the medication is we're trying to avoid precipitated withdrawal, especially in the patient population that I'm treating. And again, the reminder is precipitated withdrawal happens when that opiate is on that receptor. We remove that because of the buprenorphine and those levels drop significantly. That's when people get this terrible experience of like all of these withdrawal symptoms all at once. So I can't really communicate how terrible this is for people, but it's like, again, patients that accidentally do this or happen to do this because they don't understand how buprenorphine works, generally they only do it one time because it is an absolutely miserable experience for them. So we're trying to mitigate that as we initiate patients on there. What we're not talking about is we're not talking about achieving full elimination of cravings and withdrawals, and we're not talking about achieving full abstinence from substance use. Okay, we're really just trying to help people get started, and eventually we'll get to that point where they're not having any withdrawals or cravings. These treatment recommendations are based on the evidence of literature, case studies, and clinical experience. Again, this material is like geared towards our providers as we're training them, but really we're trying to engage in a shared decision with the patient to determine the most appropriate initiation strategy. So we really do stress the patient preference should be considered when we're trying to initiate patients on there. And sort of the bottom line of that is I can tell a patient what to do, but if they're not on board with it or in agreement with it, there's a high likelihood that that initiation strategy is not going to work. And so really want to make sure that we're including the patient in helping them understand and understand what we're doing and that they're on board with it. So here's kind of the high level overview of what we're going to talk about. So there's 3 different initiation strategies. There's 2 different withdrawal med packages that we use. And again, as we're trying to figure out what initiation strategy to use for a patient, we're looking at a few different factors. Obviously, the type of opiate is very important. How much of the opiate they're using, when they last used the opiate is really important for us. Again, patient preference, I mentioned that, and then kind of the special populations, which include like pregnant patients or patients who are incarcerated or have had some sort of forced period of time where they haven't used any substances, and so all of those things to consider. Here's the 3 initiation strategies that we use. Again, I know these slides are a little bit small, and so if you can't see them, you should have access to them later. But here's the 3 strategies we use. So there's a high dose initiation, there's a conventional initiation, and then there's also a low dose initiation. And then at the bottom of this slide, we're kind of giving you a high level view of what's going on. So in the high dose initiation, we're using this for individuals who have where the opiate has partially washed out of their system. So they've not fully gotten the opiates out of their system, but it's starting to come out of their system. With conventional, we're more looking at patients who have fully had the time for the opiate to leave their system. And then with the micro or the low dose initiations, this is where patients are are continuing to use the opiates, or they have not washed out of the central nervous system. And so, again, those are some general categories of what we're using the different initiation strategies for. So what exactly is the high dose initiation? Again, primarily when we talk about this, we're using this for patients that are using fentanyl. And what we're doing is we're giving patients a short period of abstinence where they're getting that partial washout. And then we're trying to give them a high dose of buprenorphine that's going to give adequate opiate receptor activation or agonism to where that's going to overcome their precipitated withdrawals or their severe withdrawal symptoms. So the benefits of this sort of initiation strategy is that there is a really low risk of precipitated withdrawal, although it does still happen at times. There's a low risk for it. Does not require ongoing baseline use of opiates. If you remember, I did a talk about a year ago, and we were actually recommending at that point the micro induction for our fentanyl patients. And so we'll kind of talk about that later going on, but patients don't have to continue to use opiates when they're on this. It's a faster initiation, shorter abstinence period relative to the conventional. So with conventional, you have to wait longer. This, you don't have to wait as long. And then this really helps patients with retention. We see patients that stay in treatment longer compared to the other initiations. The instructions for high dose are pretty simple. They're pretty straightforward. And then we use oftentimes the upgraded withdrawal medications, which we'll go over here in a minute. The limitations to this, again, is that patients who have experienced precipitated withdrawal, it can be a really hard sell to them to want to take a high dose of buprenorphine. Again, I tried to explain earlier how terrible this experience of precipitated withdrawals is, but this can be a real a barrier to the high dose initiation. So education is really important. And then again, this is not appropriate if a patient has low opiate use or low tolerance, and if they've gone 72 hours from their last fentanyl use. Also not appropriate for methadone patients, but we'll kind of talk more about that here as we go. I've used this slide before, but I really think it's helpful for understanding sort of what's happening with the buprenorphine as the dose increases in the precipitated withdrawal. So the lower doses here, if you start with somebody that's using opiates or fentanyl and you get into like 2 to 4 to 6 to 8, that's generally when we're getting enough activation of the buprenorphine that it's removing the majority of the fentanyl or whatever opiate is in the system. But if we don't give them enough buprenorphine, if we don't get enough buprenorphine on all the receptors, we're not getting enough activation or agonism of that to really help their withdrawal symptoms. And so again, the low doses less than 8 milligrams are more likely to cause precipitated withdrawal than the higher doses of like 16 to 18 milligrams. So this little bell curve that you see here kind of helps you understand what's going on with the displacement with the buprenorphine. Here's the what is the conventional strategy? Again, this is more of a period of abstinence that requires to allow the opiate to fully wash out. Kind of mentioned that. Again, pretty straightforward, doesn't require ongoing baseline opiate use. It can be paired with upgraded withdrawal medications. The limitations really are patients that are dependent on fentanyl. They really struggle to go the amount of time needed to have the washout because their withdrawals are so bad during that time. And then again, as we're sort of, the conventional is like 2 to 4 milligrams every hour or so. Generally, we get into that window where we can have the precipitated withdrawals. So those are some of the limitations there. Again, the low dose strategy, or the Bernese method, I think it's been called before. Again, this is like sort of small amounts of buprenorphine over the course of time while patients continue to use their baseline fentanyl. So the nice thing about this is it does eliminate the need for abstinence prior to initiating medication, allows for easier transitions, especially from methadone to buprenorphine, because that can be a really difficult transition. And then this is a good option too for pregnant patients who are dependent on fentanyl, and we'll talk more about that. The limitations of this, again, it necessitates continued baseline opiate use. So patients have to continue to have access to the opiates and willingness to do that. And I just shared at the beginning of our talk here how dangerous that can be, especially if a patient gets a bad batch or something that's really potent. This is evidence is best really for a hospitalized patient, that has sort of can be monitored. The instructions are more complicated for people to understand, especially if they're in some withdrawals when you're trying to communicate this to them. The slow doses of increase sometimes have been associated with poor retention, and then this does extend the timeline for initiation. Before I move on from the low dose, we talk a lot about sort of a kind of a low dose strategy, or especially with patients that have very low opiate use. So maybe they're on like 20 or 30 or 40 or 50 of prescribed, oxycodone. Dr. Massey does a good job of talking to us about, hey, we're actually just going to start them on a little bit of Suboxone, let them continue their legacy opiates, and then they'll slowly stop taking that over time. So again, we really do use a low dose in that strategy in a lot of ways that can be really helpful. But for the patients that I'm kind of referring to today, the patients with severe opiate use disorder that are using fentanyl, we don't use this as first line anymore. So what's changed for us with the high dose initiation? Essentially, the literature and the recommendations have changed, that it's no longer sort of a time period from the last fentanyl use, but it's more of a symptomatic experience for the patient. So whenever their last opiate use is, we wait for these severe withdrawal symptoms and two of the following signs. So dilated pupils, yawning, runny nose, sweating, vomiting, goosebumps, tachycardia. Patients have to have two of those symptoms. And again, two of those symptoms in a severe way. The way that I communicate this to patients is like, hey, think of your withdrawal symptoms on a scale of 1 to 10. I want you to be at about an 8 out of 10 on the withdrawal scale. So I want you to be feeling pretty miserable. You have to have these physical symptoms. And then at that point, you're going to go ahead and take 16 milligrams of Suboxone. So you're going to take a large dose of Suboxone. You're going to wait 60 minutes. You're going to take another 8 milligrams of Suboxone. And then you're going to wait another 60 minutes and take another 8 milligrams. So we're going up to 32 milligrams of Suboxone on the first day if the patient is still having withdrawal symptoms after those first two doses. Again, the symptom-directed abstinence can really help improve adherence because we're not giving them an amount of time for the duration of how long they can't use. And then again, this does reduce the risk of precipitated withdrawals. This little chart here kind of goes over kind of what has changed for us in recommendations. So the bottom line is high dose initiation is generally our preferred method for most cases of fentanyl dependent patients. There's a very low risk of precipitated withdrawal. I mentioned that. There's higher retention, there's easy application, and then rapidly we get to alleviate this withdrawal symptom. So for non-pregnant fentanyl patients in the past, again, a little over a year ago, we were first line recommending more of like a conventional. Second line was our low dose, and third line was the high dose. And so that has sort of like flipped on its head. Now we say, hey, high dose is probably the best for these individuals based on the drug supplies out there and what we know. We can do a conventional, and then second line would be more of like a low dose initiation. For pregnant individuals who are fentanyl dependent, our first line is going to be more of a low dose strategy. Second line will be a high dose, and then generally we do not, second line was a conventional, and then third line was high dose. And then now again, as we've sort of changed our old recommendations, now we generally want to recommend a high dose or low dose, and we do not really use conventional for pregnant individuals. And then again, I kind of mentioned this before, but in the past, patients had to wait about 24 hours from their last fentanyl use, and that was really difficult for patients, especially as the drug supply has changed. Now we just have to have them wait long enough to have two of the objective signs, and then they can start the initiation process. And again, that generally is like 6 to 36 hours if you're looking for a time frame on that, when those withdrawals will be severe enough to start. This slide just has some of the literature, kind of some of where the recommendations have come from. So we'll transition now. Let's talk with you a little bit about the withdrawal med packages that we're using. So again, what do withdrawal meds do? What don't they do? So the goal of the withdrawal medications is to reduce the opiate withdrawal symptoms during the initiation. So we are not gonna have probably the ability to eliminate all the symptoms of opiate withdrawal during initiation, but we're trying to help with that. So really important is we're educating our patients, especially if they're brand new to Suboxone and treatment, that we're giving them sort of realistic expectations of what to expect when they're initiating on the medication. So Withdrawal meds can generally not fully eliminate symptoms, but they should improve the patient's comfort. Our goal is to try to educate patients to try to stay ahead of their withdrawal symptoms. So we want to have them, they get as needed medications, but we're trying to encourage them to pre-treat some of those symptoms when they first start to experience them and not really get behind on their withdrawals, and really take them as scheduled initially. And then again, opiate withdrawal symptoms are going to be more severe with, longer duration of use. So how long they've been using the substances, the heavier amount of substances, and then the longer time since the last opiate use are all going to be relevant in what kind of withdrawals they're going to be experiencing. So in most cases, upgraded withdrawal med package that goes with clonidine, 0.1 milligrams 4 times a day. Again, always reminding patients that this medication can kind of lower or tank their blood pressure, and they can kind of get lightheaded if their blood pressure tends to run a little bit low. The hydroxyzine, we use 50 to 100 milligrams 4 times a day for individuals as needed. We've added gabapentin, so we used to not use gabapentin, but we've added that. Patients can take 300 milligrams 4 times a day. And then Zofran is also really important because patients do experience a lot of nausea, not only with the withdrawals, but sometimes with the medication as they start it for the first few times. Tizanidine and lifoxidine, again, other options, but a lot of times these need prior authorizations. And so we just don't have time to get that done and get that to the individual while they're trying to initiate after they see us. And so generally we're not using those medications, but they are options. This is sort of what our standard withdrawal medication package used to look like. So again, similar medications, but the clonidine was just twice a day. Hydroxyzine was just 50 milligrams 4 times a day. And then the Zofran was the same. It was 4 milligrams twice a day. So again, how do we pick which, withdrawal meds to use? So generally speaking, if we're doing a high dose initiation or a conventional, we want to use the upgraded withdrawal medication package. For low dose initiation, a lot of times we use more of a standard withdrawal. And then again, the caveat here is just a lot of times we see patients who are already on some of these medications, specifically gabapentin. We see a lot of patients that are on that already. But what our recommendations are in those situations is just that we just have them continue their baseline use. We're not going to increase that. And then obviously we don't want to prescribe any medications that are contraindicated or have any sort of drug-drug interactions for the individual. So this slide just kind of goes over the standard upgraded withdrawal. Again, we're always with any medication, we're trying to talk about the benefits of the medication versus the risks and side effects. And so again, this kind of goes over the medications with either standard or upgraded withdrawal dosing and kind of what symptoms and then risks and considerations. So the gabapentin, mainly upgraded withdrawal, restlessness, anxiety, sleep issues can cause some CNS depression. We want to make sure that patients are not misusing or becoming dependent on that. And then we do tend to avoid this with benzodiazepines or alcohol use. Again, clonidine, you can kind of see across there. We don't want to use this with cardiac abnormalities. Talked about the hypotension, and then always making sure we're discontinuing this medication after initiation, which really we don't continue to prescribe these longer than about 5 to 7 days. Hydroxyzine can be helpful for anxiety, restlessness, insomnia. Again, there's the risks and contraindications there. And then the Zofran, the main concern is serotonin syndrome or maybe some QT prolongation. But again, sort of shows you the dosing on those. I can refer to this on the last slide, but the duration of medications, generally around 3 to 5 days of withdrawal medications is sufficient for the individual. We tend to not prescribe these much longer than 7 days. Again, patients a lot of times will ask for ongoing sort of clonidine or maybe some hydroxyzine, things like that. Again, gabapentin, they get a lot of benefit from that and they want to continue that, but we try to just set clear expectations right away. And again, that's partly just because the way our practice is set up, we're mainly just managing that. And so if patients need to have a medication for a longer period of time, we'd encourage them to go to their primary care doctor. We don't generally recommend continuing any of our medications, including Zofran, but I do see a lot of our patients that continue to take Zofran prior to dosing, and I personally will continue this medication if the Zofran is being used primarily to help patients, take the medication. What we don't want to be doing in our practice is prescribing a medication and masking another symptom without being able to have the ability to sort of evaluate that more fully. There are a few additional withdrawal meds that you can see here. Dicyclomine, ibuprofen, mirtazapine kind of shows you similarities of what we use those for, risk considerations, kind of initial dosing. And so we generally don't use these, but in a case-by-case situation, if a patient is having significant symptoms in one of these areas, we will prescribe those medications as well. So we're going to talk now a little bit about like how do you decide kind of which strategy and type of medication to use in which individuals. And so again, I know you can't read this slide, but these is just sort of a initiation strategy decision tree. And again, you'll have access to this if you want, but this is for not pregnant patients, but it sort of just walks you through yes, no questions and helps you get to the right answer on which package we're going to use. I'll walk you through the pregnant patient one because it's a little bit smaller and you can kind of see it a little bit better. But essentially, if we have a patient that is pregnant with active opiate use that comes to the clinic, first thing we're going to say is like, hey, are you willing to go to like medically managed detox? And if the answer is yes at the top there, we go to detox. And then once they get out, we kind of manage them afterwards. If they're not willing to go to detox, we're going to try to document that and then say, hey, are you willing to go to a methadone clinic? Because the methadone transition from fentanyl to methadone does not cause any precipitated withdrawals. Yes, if they're willing to do that, great. If they're not willing to do that, all right, let's talk about what type of opiate are you using? Is it a short acting? If it is, we're going to try to recommend a conventional strategy. If it's methadone, we are going to stop at that point. We're going to go to the methadone decision tree. If it's fentanyl, we're going to say, hey, do you have continued access to fentanyl? Is that something you're continuing to want to or willing to continue to do? If the answer is no, we're going to do a high dose initiation for that individual. If the answer is yes, we're going to discuss the benefits and risks of both the high dose and the low dose with the individual. And then we're going to try to make a shared decision. And again, at that point, we may still go with the high dose or we may transition to low dose. So again, this is just one of the tools that we use that helps us decide, hey, what strategy are we going to use for the individual patient? This is a kind of another way to look at this. It's just a matrix. So it's a short-acting opiate on the left side. Is it fentanyl or is it methadone? What strategy are we going to use? So short-acting, generally conventional with upgraded withdrawal medications. If it's fentanyl, we're going to start with high dose. Also, conventional could be first line, and then low dose is really our second line. If we do the low dose, we're going to do standard withdrawal medications. If we do a conventional or the high dose, we'll do the upgraded withdrawal medications. And then with the methadone, if there's a patient that gets sort of kicked out of a methadone program or they no longer have access to methadone, we're going to go with more of a conventional initiation. And then if they are transitioning where they can continue to use their methadone, we're going to do a low dose, and both of those with some standard withdrawal medications. This is the slide that I think I maybe referred to earlier, but essentially we're trying to determine the anticipated buprenorphine daily doses. And so it's just a helpful tool for you to have based on, what type of opiate the patient is using, how much they're using, and where their target dose is, hopefully going to land somewhere close to there. So again, just the caveats on this, it's an estimate. So it's a general starting point. Again, we're going to evaluate the patient, may have to go up or down on their dose. And generally, we're trying to see our patients a couple times a week, at least once a week when they're initiating or at least have access to us. And then the kratom, we've done talk about kratom in the past, but those formulations are really difficult for us to know how much buprenorphine someone's going to use. So we have some general categories here, but the kratom does really change a lot. And so with those individuals, we just need to really keep a close eye on them as we're initiating. A little bit of a slide here about daily doses for special populations. So we're going to be doing a talk here soon with the correction centers, but for recently sort of incarcerated patients with a history of opiate use disorder and a period of abstinence, not taking buprenorphine or other opiates, we just sort of need to account for the loss of opiate tolerance and dependence in those individuals. If a patient is not physically dependent on opiates, we don't use the withdrawal medications. We just start them on the buprenorphine. And then again, we would say prolonged abstinence is more like greater than a month. And then short-term abstinence, we say is less than a month. So again, if it's a longer period, we would generally start with a lower dose of Suboxone, 2 milligrams, kind of monitor for sedation. And then we'll slowly increase this dose over time. For patients that have been abstinent for a period of time too, we do like to discuss naltrexone and Vivitrol. Again, those are the opiate blocker. Those medications are less and less recommended by us for patients that are specifically coming out of incarceration. Again, there is value in those medications. They don't help as much with the actual cravings or desire to use opiates. And then again, the danger is if somebody gets out of a situation where they've had a forced taper and they stop using their naltrexone or their Vivitrol injection, they're not on time with it, and they have a return to use, there's a really significant risk of overdose in those individuals. So the nice thing about these individuals is the time where you can initiate it, because otherwise they have to, go through the withdrawal stages of the buprenorphine or the opiates. But again, it's worth a conversation. We don't recommend it often. And then if there's short-term abstinence, we try to prescribe buprenorphine the lower doses than previously prescribed. If they haven't been previously prescribed, just lower dose that you would for an active one, and just sort of titrate that up. All right, so now we're going to kind of transition and talk about kind of each of the individual opiates and kind of which initiation strategy to use. So again, short-acting opiates, heroin, morphine, hydrocodone, oxycodone, kratom. Generally, we're going to use more of a conventional initiation for this individual with upgraded withdrawal medications. Again, these opiates generally have a shorter half-life, can allow for this complete washout with around about 18 to 24 hours. And then the upgraded withdrawal medications can support and help the patients with the withdrawals until they can start the buprenorphine. And so, again, at the bottom of the slide, you can see the protocol here. So last opiate use, 18 to 24 hours, take 2 milligrams. If the patient experiences severe withdrawal symptoms, we may pivot them to more of a high dose initiation at that point. So we may try to give them a lot more Suboxone. If they're not having severe withdrawal symptoms, we're going to have them wait 60 to 90 minutes, take another 2 to 4 milligrams. And we're going to just repeat that until they get to close to what the target dose is based on their opiate use. There's a handful of kind of knowledge checks, and we'll kind of go through these quickly here. But so assume you had a 20-year-old female, presents with opiate use disorder, says that she's smoking, 0.5 grams of this white powder fentanyl daily for the last year. Her last fentanyl use was 4 days ago. She has been using kratom to self-manage the opiate withdrawals. And so the question is, hey, which initiation strategy is most appropriate in which withdrawal medication package? And again, for this individual, we're doing the conventional initiation with the upgraded withdrawal medication. So don't let the previous fentanyl use fool you, because it's been over 72 hours. We're really basing the initiation at this point off of the most recent kratom use. All right, so fentanyl patients, again, generally speaking, high dose with upgraded withdrawal medications. The alternative is conventional with upgraded, and then second line would be more like a low dose with standard withdrawal medications. Again, short period of abstinence allows for this partial washout. We kind of talked about that. We're going to initiate with a large amount of buprenorphine. We're displacing whatever fentanyl is not already removed with time, and then we're trying to activate that receptor to overcome the withdrawals. Should always try to prescribe upgraded withdrawal medications for these individuals. And again, we're not using the fentanyl, or we're not using the high dose if it's been greater than 72 hours since their last fentanyl use, or if they're using methadone. Okay, so the protocol, again, last opiate use, wait for the withdrawal symptoms, take the full 16 milligrams, wait 60 minutes, take another 8 milligrams. And again, they can take the final 32 milligrams if they need to, if they're still having withdrawal symptoms at that point. One just quick sort of caveat on this one. When you're prescribing this for individuals, a lot of insurances will not cover 4 tablets on day one. And so a lot of times you have to just write this as 3 tablets a day and maybe give them an extra day of medication so they have enough to take the 4th one. It's a lot easier to get approved an early fill of medication than it is for 4 on the first day. It just causes a lot of problems with that. So one of the caveats on just prescribing that. If we do a conventional initiation for fentanyl, again, the reminder on that is that fentanyl has a longer half-life, so it can stay in the patient's system for longer. And so we want to do the upgraded withdrawal medications to really support them until they can get to the 36 to 72 hour mark. And then again, we wait for that period of time. We give them 2 milligrams and we kind of see how they do. If they're not having severe withdrawal symptoms, we can give another 2 to 4 milligrams. But if they are having the severe withdrawal symptoms, we sort of try to pivot them to more of the high dose initiation at that point. Low dose initiation for fentanyl. Again, this is what we were recommending first line just a year ago, and it was sort of initiating small doses of buprenorphine overlapping with ongoing baseline fentanyl use. Again, we do this generally over the course of about 7 days until we can really build up the buprenorphine, and then they can stop that. Again, it eliminates the needs for abstinence, and it decreases the risk of precipitated withdrawal. The thing to really drive home in the low dose is, like, patients really need to continue their baseline use of whatever the opiate is, but we're talking about fentanyl here. So they need to continue their baseline fentanyl. If they start to lower their fentanyl use over the first several days as they're increasing this, they're really going to get themselves into some withdrawals, and they're not going to feel very well with that. All right, so 35-year-old male, 20 blue pills a day. Last fentanyl was 1 hour ago prior to arrival. He is out of his supply, unsure if he can access more, no prior experience with buprenorphine. Again, what strategy, what withdrawal medication package? Again, we're doing the high dose upgraded withdrawal for this individual. 24-year-old male, opiate use disorder. He says he's smoking 12 blues a day. Last fentanyl was 3 hours prior to arrival. He wants to proceed with the first line recommendation of high dose initiation with the upgraded withdrawal medications. But the question is, what instructions should you give the patient for when to take the initial bolus or dose of buprenorphine? And again, what we're looking at in those individuals is generally in like a 6 to 36 hour window, but we're really looking for 2 of the physical signs of withdrawals in a severe way, somewhere around an 8 to 10 on the scale of the individual. Then they can initiate that first bolus. And then a 50-year-old male stating he was released from prison. Okay, so we talked about this. He's been incarcerated for a year. Prior to incarceration, he was smoking about 22 fentanyl tablets a day. Last fentanyl use was a year ago prior to incarceration. Cravings has worsened significantly after getting out, which is pretty common. We discussed the options of the Vivitrol and the naltrexone, as well as the buprenorphine. He wants to go forward with the buprenorphine. And really important here, he does understand the risk of developing dependence on the medication. So again, for these individuals, we want to educate them that if they start back on the buprenorphine, their body is becoming dependent on that, and coming off the buprenorphine is going to cause withdrawals. And so we want to make sure that patients are well aware of that when we restart them. So what initiation strategy and then what withdrawal medication package for this individual? Again, we're going to do a conventional. We're going to start really, really low, like 2 milligrams. We'll titrate that up. But again, in these individuals, we don't generally prescribe the withdrawal medications because they don't need them because they're not actively in withdrawal. One note at the bottom of this page is this: for all of our individuals that we prescribe Suboxone to, we always prescribe Narcan. The main thing is with the buprenorphine, theoretically, because it's absorbed orally, if a child got a hold of it and got it in their mouth, that could theoretically cause an overdose. We always want patients to have Narcan available. In those situations, we would say, hey, give the Narcan right away and call 911. But all of our new patients, we prescribe the Narcan or the Kloxxado, which is the upgraded one. All right, let's talk about methadone for a little bit. The transition from methadone to Suboxone can be one of the most difficult transitions for individuals to make. So, excuse me, patient presents requesting transition from methadone to buprenorphine. They do have access and willingness to continue their baseline methadone. So again, if that's the case, we generally say we want to get the ROI from the methadone clinic provider so we can talk to them. In this situation, we're going to initiate a low dose strategy with standard withdrawals, continue the baseline methadone for the first 6 days. And then on day 7, we're going to discontinue that once we get to the target dose. Again, one of the caveats here at the bottom is for methadone doses that are higher than 120 milligrams. The general time is like, I think it's like 10 milligrams per day is like the washout, but then or 7 days, whichever comes first. But sometimes with these higher doses of methadone, it can be a little bit more complicated. And so we have a consult line with an ideal option, but also Project Echo. Part of the things we're trying to do is be a helpful resource. So if you ever run into situations that are more complicated, we would love to have you reach out and kind of talk through how to work through that. So a different methadone situation is someone that comes to you and says, hey, I got kicked out of my methadone program, or I moved, or I can no longer go there because I have a new job, and I just can't continue to do it. So in these individuals, assess if they have adequate methadone washout occurs on the baseline methadone use, and then we're going to go with a conventional initiation strategy. And so again, the washout period is it's like 10 milligrams per day or 7 days, whichever comes first. The sort of protocol there is at the bottom. Again, I've helped a lot of patients make this transition, and the hard selling point in this is just really encouraging patients to wait the 7 days or wait the allotted amount of time. I've had more than one patient that has, that we've made them wait for a while. We've kind of prescribed them medication and said, hey, don't start taking the buprenorphine for a couple of days, because that's when the washout period will be. And they'll come to you and they'll tell you how terrible they feel and how bad the withdrawals are and how they can't stand it. And then they come back to you after they take their buprenorphine too soon, and they said, I was not in bad withdrawals at all compared to what I experienced taking the buprenorphine too soon. So again, throwing them into that kind of precipitated withdrawal. And so really encouraging these patients to wait long enough, because again, these are obviously not ideal situations if they have to abruptly stop their methadone. And then again, situation 2 is a patient who suddenly stops methadone, but they're actually using illicit opiates. And so if there's, continual use of illicit opiates, we may use like a low dose strategy. But if it's been like a period of time, like let's say methadone last use was 5 days ago, but now the patient's been using fentanyl for the last couple of days, then we would base the initiation off of that last fentanyl use, as long as there's been adequate washout from the methadone. All right, a couple of knowledge checks here, and then I'll kind of go through a couple more things, and then I'll take a little break and just see if we have questions, and then we'll kind of finish out on what we don't get to, or else you can have the information. But a 40-year-old male, new patient, stable on maintenance dose of methadone 100 milligrams a day for 3 years. Again, got a new job, wants to transition to buprenorphine, can continue to go to the methadone clinic to receive his daily dose during the initiation. How do we handle that individual? Again, we do a low dose with standard withdrawals for that person. New patient, 36-year-old female, requesting assistance transitioning from methadone to buprenorphine. She's been on the maintenance dose of methadone, 60 milligrams for 2 years, cut off by her provider for her illicit benzodiazepine use. Last methadone was 4 days ago. Last illicit opiate was 2 years ago. She is in withdrawal. So what do you do in preparation for initiation? And then which strategy would be best for this, which withdrawal package? And again, so prior to initiation, the patient's on 4 days of abstinence from methadone. We want to give her those upgraded withdrawal medications to allow for adequate washout, which is typically going to be around 6 full days, because it's 10 milligrams per day. And then at that point on day 6, if they haven't returned to any opiate use, we're going to do more of a conventional initiation with upgraded withdrawal medications. If on day 6 the patient did return to illicit opiate use, which is not uncommon for these individuals because they feel so terrible, then we're going to again base the initiation strategy off of the last opiate use. And again, sometimes we need to kind of reach out to our colleagues and try to figure out what's best in those individuals. Talk briefly here about pregnant patients. Again, the highest recommendation is always medically monitored detox or management with methadone. There is sort of limited guidance from the literature supporting a specific initiation strategy for pregnant patients in the outpatient setting. from our standpoint, these patients can and should be managed in the outpatient setting if they refuse or they're unable to receive treatment at a higher level of care. So again, the risk benefits, we're always looking at maternal withdrawal and fetal stress, the risk of ongoing illicit opiate use, and then compliance with the instructions in trying to retain these patients in treatment. So high dose, again, generally beneficial, low risk of precipitated withdrawal, don't have to continue to use the opiates, faster initiation. It does require a period of abstinence. So although that's a short period of 6 to 36 hours with 2 symptoms, this can cause maternal withdrawal, which can lead to fetal stress. And then again, the low dose initiation is another option. Generally, we do not recommend any conventional for these individuals just because of the amount of time with the withdrawals. Again, if there's a pregnant patient that has a short-acting opiate, we do still use conventional first line. Again, fentanyl, we have the discussion about high or low dose. And then methadone, again, really difficult transition. Ideally, we don't really want to do those, but we would do a low dose if possible in that, if we could. Okay, so a couple knowledge checks again. 30-year-old female, pregnant, 16 weeks, 10 fentanyl pills a day for several months. She's motivated to get clean. Last use was 4 hours ago. She does have access to fentanyl, but as of today, she's committed to staying clean. What do you want to do in preparation? What strategy? And then what withdrawal medication package? Again, always strongly encourage admission to medically managed detox or methadone, document the refusal, and then we discuss the risk benefits of both the high dose and low dose. Again, preferred initiation strategy with withdrawal is the high dose with upgraded, but again, we do need to discuss the risk and benefit of the medications with the patient, specifically some of the withdrawal medications. This individual will be a 23-year-old female, 12 weeks along, gradually using more and more opiates over the last 2 years. For the last couple of months, she's been snorting 14 blues or fentanyl pills a day. Last use was an hour ago. She has access to that and expressed that she does not want to experience any withdrawals during the initiation process after previously failing a conventional initiation a few years ago. Again, what do you do in preparation and what's most appropriate? Similar stuff. Encourage them to go to inpatient, document the refusal. We're going to go with a high dose upgraded package or the low dose standard withdrawal package. And then try to have a risk benefit with the patient and have a shared decision in that. I'm going to push pause right here. There's a couple of things left here about increasing the likelihood of success of initiation and then unsuccessful efforts, but I want to leave a little bit of time for any sort of questions or discussion. If people have put anything in the chat or they just want to holler out, we can do that.
Yeah, great. I see one question in the chat, so we can start there. Question from Clinton asking, how do you decide that the risk of dependence on buprenorphine is worthwhile?
Yeah, that's a good question. So again, when we're talking about opiate use disorder, when we diagnose a patient with opiate use disorder, we view this as a chronic long-term disease process. So with any chronic long-term disease process, sometimes we manage that with medications long-term. And so again, when we're a lot of times starting patients on buprenorphine, the dependence is already there. Like the patient is already dependent. And so we are transitioning them to a safer, longer acting medication. But if the question is more specific towards like an incarcerated patient coming out or someone who no longer has been using opiates for a period of time. I just saw a patient the other day who weaned himself off of Suboxone, had been off of Suboxone for, I think, 4 or 5 months, and actually came back to us wanting to get back on the medication. Again, in those individuals, it's just a conversation with them of, hey, what do you understand the risk of the medication and what do you want to do? Because a lot of these patients will say, I'm getting into life stressors, I'm having more cravings, I don't want to go back to opiate use. And so with those situations, then we say, okay, like the recommendation is still at any period of time, if you've had an opiate use disorder, even if there's been a 12-month gap, that we can restart you on the buprenorphine, and just educating them on the recommendations in those situations, I think is really important. So that's how I weigh it, is like I have the conversation with them, but if they've had a history of the opiate use disorder, it is recommended still to offer them the Suboxone and the buprenorphine if they want to go that route.
I want to make a few comments here that we clarify. So what's happened through time, and when I worked at a methadone clinic for years, and we would transition people from methadone to buprenorphine in some cases. So lots and lots of patients over time. The strategies to dose buprenorphine are evolving and now mirroring somewhat what we've known for years for methadone, which came out a long time ago. And so it's kind of catching up. A couple points to remember that are kind of important. Buprenorphine is the safest, but the data right now, as well as I can say it from experience, for people that are using high dose, high potent things, buprenorphine doesn't work as well as methadone in most cases. There's some exceptions to that, but it does not. And so you have to kind of give that consideration. A couple other variables that are really important in terms of retention and treatment. Buprenorphine does not do as well as methadone. And so now the methadone guidelines are being relaxed somewhat, meaning that for someone who is starting a new job, and I know that Ed talked about this, because of the guidelines being relaxed, methadone may be an option for them. And so it's something to think about when someone's got a real severe addiction and using very high kind of doses or high potent kind of agents. The other thing, and if you forget everything I've just said, don't forget this point, please. A woman who has moderate to severe OUD needs the standard of care is for them to remain on opioid, whether it's buprenorphine or methadone. It's not to detox, so I want to be really clear on that. The standard of care is for them to remain on that. If they want to detox, that's a different discussion, but outcomes are overwhelmingly better for women that are pregnant that have moderate to severe OUD for them to remain on either buprenorphine or methadone. So I want to make sure those points are clear. They were touched on a little bit, but I don't want there to be any confusion around that. Thinking, oh, if a woman comes in and she wants to detox, and okay, I'm going to go along with that detox conversation, right? I'm suggesting you don't go along with that without having a detailed discussion with her around kind of the typical standard of care and the typical outcomes.
Yeah, excellent points. And I think if I communicated, medically monitored detox, what I probably should have said was we want them to be medically monitored in the transition onto the buprenorphine or the methadone, somewhere where they can actually be monitored and the baby monitored. But excellent points.
We've got another question in the chat here asking, why is methadone a better first consideration?
So and Dr. Stoll's got more experience with methadone than I do, but the methadone, the way that it works is it does not have this blocking component where it removes the opiate from that receptor. And so patients who transition from fentanyl onto methadone, the way I understand it, is there's no withdrawals at all. They can actually start that medication right away, and they can titrate that medication up, and they don't run into any issues with the precipitated withdrawals with the transition to methadone. And so, again, there's been some limitations with methadone as far as access and daily dosing, and hopefully those things are changing because methadone's been around for a long time and has been a really helpful medication. But that's the reason that transition is a lot easier for individuals.
Thank you. We've just got a comment I want to read from Alex, one of our ECHO panelists, who will probably be giving a talk about pregnancy and opioid use disorder in this next cycle of trainings. Just following up on what Ed and Todd were saying about treating OUD in pregnancy. He says 100% yes, healthy mom equals healthy baby. Patients can be assured that babies will be monitored by NICU staff and do well post-delivery. So we've got a few minutes left. Any other questions or Ed, anything else you would like to cover in this remaining time?
I'll just go over this slide and then we can shut it down. So again, this is just some recommendations on increasing the odds of patient success. So again, the dosing of the medication is always important. The medication is primarily absorbed in the mouth, and so really recommending no eating, drinking, smoking, vaping 30 minutes prior to dosing the medication. Appropriately sort of like following up with these patients and having connection where they can call and touch base. If a patient can get into, peer support, handouts, and then realistic expectations, I kind of stress that throughout the time, but realistic expectations of what to experience and what the patient can do if they do start to feel some withdrawals or precipitated withdrawals. And then again, one of the things we always stress is with the individuals we're seeing, like they know that they have a substance use disorder and they know that they're struggling. And so we tell patients, hey, no matter what happens as you start this medication, please come back and have another conversation with us. If one of the initiation methods don't work, we can figure out why it didn't work. We can transition you maybe to another initiation method or help get you the support that you need. And so again, probably the take homes on this is just the dosing recommendations with this. And again, one other call out on that, the Suboxone long-term use of that medication is really hard on people's teeth in certain individuals. And so really educating patients on that, making sure that they're doing good hygiene, rinsing their mouth out, brushing their teeth can be really important, but making sure that patients understand that one of the side effects of the medication can be really difficult dental issues. Some individuals have been on it for over 10 years and have no dental issues, but some people have been on it for a year or 2 years and they tell me that they begin to have some troubles with that. So that's all I got for you, Will.
Thank you, Ed. Great presentation. And those slides will be sent out in about an hour or two after we finish up here. That'll come in an email along with the link to the evaluation survey. So just a reminder, complete that evaluation survey to get your certificate. I also put a link to that evaluation survey in the chat if you want to grab that now. And that'll do it for today. I guess we'll hope to see everyone back here in a couple weeks. Stephanie Bennington will be talking about some medications for off-label medications for substance use disorder treatment. So we'll see you back then. Thank you.
Thanks.